Good evening, everyone. Today, let's study about inflammatory bowel diseases. Inflammatory bowel diseases. We call it as IBDs. So, here we have two types, which is Crohn's disease and ulcerative colitis. Ulcerative colitis. So, what is inflammatory bowel disease? It is a group of disorders characterized by inflammation and ulceration of GIT, and the two main forms include Crohn's disease and ulcerative colitis. Now, coming to the etiology, what can be the causes leading to inflammatory bowel diseases? So, the causes which cause inflammation and ulceration of GIT, it is actually complex. I don't know. Mostly it is genetic. So, complex or multifactorial. Most likely, it is established that a sustained response of the immune system to enteric flora. Sustained response to enteric flora. This is like lack of appropriate downregulation of immune responsiveness after an infection. So there can be an infection and which might have caused increased immune response, but there is lack of appropriate downregulation of immune response. So continuously there will be immune response leading to inflammation of the bowel. So these are the causes of inflammatory bowel diseases. Coming to genetics. So these inflammatory bowel diseases are mostly genetic. So if the patient has ulcerative colitis, he might be prone to see Crohn's disease also, and vice versa. So, increased risk of both ulcerative colitis and Crohn's disease in relatives of patients with either disease, especially siblings, early onset diseases. Okay, so familial risk is there for ulcerative colitis and Crohn's disease. It's usually polygenomic, 200 plus gene loci are associated with the etiology, and some mutations like CARD15 NOD2 gene mutations can cause inflammatory bowel diseases. You might have heard about the NFKB gene products, like they call it as NFKB, associated with these inflammatory bowel diseases, mostly Crohn's disease. It is required for the innate immune response to microbial pathogens expressed in monocytes and macrophages. So this gene mutations might have caused the IBDs. Yeah, these are the results of studies. Okay, so these are the gene mutations. Now coming to the study of ulcerative colitis and Crohn's disease, it's better to study this comparatively. You can take Crohn's disease on one side and ulcerative colitis on the other side, and study comparatively. This makes the study easier, right? So we can start with the location first. Okay, location. So coming to location, Crohn's disease usually involves any part of the GIT, Okay, there's no restriction. So usually we call it as, in a funny way, gum to bum. So it can happen anywhere throughout the GIT, here. So gum to bum, it can happen anywhere. Okay. Coming to ulcerative colitis, it is usually isolated to large bowel. Large bowel. Okay. Always involves rectum and might progress proximally. So the Crohn's disease can happen anywhere, and ulcerative colitis is usually restricted to large bowel. Remember this, always involves the rectum and can progress proximally too. Okay. Now, what about rectal bleeding? So usually when this small bowel or large bowel gets involved, we actually are concerned with something called rectal bleeding, right? So rectal bleeding is nothing but the patient finds blood in his stools. So usually that is uncommon in Crohn's disease, but very common in ulcerative colitis. Because ulcerative colitis, as you all know already, it involves rectum, so there will be more bleeding. What about diarrhea? So this is about rectal bleeding. Okay. Now, what about diarrhea? Diarrhea in Crohn's disease, usually non-bloody, because it mostly involves the small bowel. If at all it involves the rectum, it can be bloody, which is, particularly if distal colon is involved, there will be bloody diarrhea, or else it will be non-bloody diarrhea. So diarrhea will be there in both. In ulcerative colitis is much more frequent, and mucus will be present, and it will be bloody, and there will be small volumes of stools. So the patient will be very irritable, like he will be going to pass his stools frequently, and there will be mucus passing along with the stools, and it will be bloody and small volume of stools every now and then. So this can be the presentation in ulcerative colitis, whereas Crohn's disease, usually it will be non-bloody diarrhea. Okay, now coming to the abdominal pain. It's present in both. In Crohn's disease, usually it will be postprandial colicky pain. Here in ulcerative colitis, it will be pre-defecation colicky pain. So, Crohn's disease and ulcerative colitis, right? Okay, so we have finished diarrhea and abdominal pain. Now coming to fever. It will be very common in Crohn's disease. It is not so uncommon in ulcerative colitis. What about urgency? Urgency is uncommon. Urgency, or we also call it as tenesmus, that irritable feeling. So it's usually uncommon in Crohn's disease, whereas it's very common in ulcerative colitis. As discussed before, these patients will be having frequent passage of stools. So there will be urgency, much more common in ulcerative colitis, whereas not so common in Crohn's disease. Okay. Now coming to palpable mass. Frequent in Crohn's disease, rare in ulcerative colitis. But if it is present, it's usually due to due to cecum full of stools. Full of stools. So if there is stools in the cecum, that can cause the palpable mass, or else it's very rare in ulcerative colitis. But in Crohn's disease, it's usually frequent. What about recurrence? Recurrence after surgery. Recurrence after surgery. It's common in Crohn's disease. Usually in ulcerative colitis, what we do in surgery is just colectomy and then permanent ileostomy. So there can be no recurrence because we would have already, taken out a part of the large bowel, the colon part. So there will be post colectomy case scenario, and there will be permanent ileostomy. So it's none. It's none in ulcerative colitis. What about endoscopic features? Let's go for endoscopic features. Endoscopic features in Crohn's disease. We might have heard about the skip lesions, right? Skip lesions. So, what are skip lesions? There will be pathology to some distance of the small bowel, and then again there will be normal bowel, then again some pathology, then normal bowel, then pathology, then normal bowel. So this will be the scenario. This is nothing but the skip lesion. So endoscopically, you will be seeing, what will you be seeing? So usually it will be segmental inflammation. Segmental inflammation associated with ulcers. We call it as aphthous ulcers. Aphthous ulcers or stellate. Aphthous or stellate or linear ulcers. Then there will be patchy lesions. Patchy lesions. Pseudopolyps, and cobblestone appearance. Okay, so these are the features associated with, endoscopic features associated with Crohn's disease. What about ulcerative colitis? Endoscopic features of ulcerative colitis. There will be continuous diffuse inflammation. There won't be any skip lesions, mind it. So skip lesions are present in Crohn's disease, which is nothing but the segmental inflammation. But in case of ulcerative colitis, it will be continuous diffuse inflammation. And there will be erythema, friability, loss of normal vasculature, and there will be pseudopolyps. Polyps are usually present in both, but the major difference is there will be segmental inflammation in case of Crohn's disease and continuous diffuse inflammation in case of ulcerative colitis, and there will be ulcerations like aphthous ulcers, all of those in case of Crohn's. But here, along with the ulcers, you will find erythema, friability, and loss of normal vasculature, also pseudopolyps. Cobblestone appearance is present in Crohn's disease and not in ulcerative colitis. Remember that. What about histological features? Histological features. Crohn's disease is known to involve the whole of the mura, that is, it is transmural. It involves whole mura. Okay, so mucosa, submucosa, musculature, it involves everything. So it is transmural, it is through and through in the wall of the GIT, that is Crohn's disease. Okay, transmural distribution along with skip lesions. Then there will be focal inflammations too. Okay, so there will be skip lesions, there will be focal inflammations, and non-caseating granulomas, deep fissuring, because it involves whole of the wall. Okay, whole in the sense WHOLE. Okay, whole of the wall. So there will be fissuring, there will be abscess ulcerations, strictures might present, strictures. But one thing is, glands will be intact. Glands will be intact in case of Crohn's disease. What about ulcerative colitis? Here, it's only the mucosal distribution. It's only the mucosal distribution. It doesn't involve whole of the wall of the GIT. Okay. So it involves only the mucosa. So mucosal distribution, and it's a continuous disease. Which means the same as there is no skip lesions as it presents in Crohn's disease. Okay, so there are no skip lesions in case of ulcerative colitis, but it involves only the mucosa. But the whole segment of the large colon will be involved. Just remember that there are no skip lesions, and it doesn't involve whole of the wall. It involves only the mucosa. So there is mucosal distribution and it's a continuous disease. Mucosal distribution and continuous disease. There will be architectural distortion of whole of the large bowel. So the large bowel will be, mucosa of the large bowel will be wholly distorted. And there will be gland disruption. Whereas in case of Crohn's disease, we don't find gland disruptions. Glands will be intact. But in ulcerative colitis, there will be gland disruption. And crypt abscess can also present. Crypt abscess and granulomas. Crypt abscess will be present, whereas granulomas will be absent. Non-caseating granulomas will be present in the Crohn's disease. Granulomas will be absent in case of ulcerative colitis. So let's summarize this part, histological feature. So Crohn's disease is transmural, whereas ulcerative colitis involves only the mucosa. Crohn's disease is there will be segmental inflammation, whereas in case of ulcerative colitis, it involves the whole of the large bowel, starting from the rectum, might progress proximally. So it's a continuous disease. And in case of Crohn's disease, there will be non-caseating granulomas, whereas in ulcerative colitis, granulomas will be absent. Then deep fissuring, fistulae formation, all of those will be present in case of Crohn's disease, whereas they are absent in case of ulcerative colitis, because ulcerative colitis is restricted only to the mucosa. Okay, so this is about histological features. Now coming to the radiological features. In the radiological features, we find the Crohn's disease presenting as cobblestone in the mucosa. So if you go for colon enterography, CT enterography, etc., there will be cobblestone appearance of mucosa in case of Crohn's disease. Okay, cobblestone mucosa. And there will be frequent strictures, fistulae, etc. in case of Crohn's disease. And abdominal X-ray shows bowel wall thickening, known as string sign, because there will be skip lesions. So that in abdominal X-ray will be visible like string and beads. So if this is the pathological area, this will be the normal area. Normal area, pathological area. Normal area, pathological area. So this will present like a string of beads. Okay, in Crohn's disease. In case of ulcerative colitis, when we radiologically investigate the mucosa of the ulcerative colitis in a patient with ulcerative colitis, we can see lack of hostra. Lack of hostra. Normally there will be hostra, but in case of ulcerative colitis, there will be total distortion of the mucosa of the large bowel, so there will be loss of hostra, and strictures are very rare. If present, need to rule out some complicating cancers. Okay, strictures are rare. So this is about radiological features. Radiological features. Now, what about complications? Complications of Crohn's disease and ulcerative colitis. Complications of Crohn's disease. Complications. So, as we already have studied about this, it will present with strictures, fistulae, perianal disease. What about ulcerative colitis? The only complication of ulcerative colitis is toxic megacolon. Toxic megacolon. Usually this happens after there is presentation with cryptabscesses, diffuse ulcerations, and total gland disruptions. So all of these will cause toxic megacolon. Maybe after an infection, the colon will just distend and be toxic megacolon. What about colon cancer risk? Colon cancer risk increased in case of Crohn's disease if greater than 30% of colon is involved. If greater than 30% of colon is involved, there is increased risk of colon cancer in case of Crohn's disease. But in case of ulcerative colitis, it is anyhow increased, except if the patient has proctitis. Okay. So this is about the differences between Crohn's disease and ulcerative colitis. So let's end the video here. I'll talk about the extraintestinal manifestations of these diseases and how to treat Crohn's and ulcerative colitis later in the next videos. For now, let's just summarize with So let's summarize the whole IBD, inflammatory bowel disease, involving Crohn's disease and ulcerative colitis and all the differences between them. Just go through the video in 2x just to revise this, and hope it will be helpful for you all. Thank you.